So, dear viewers, I'm Dr. Rakesh Gupta. I'm president of Sipher and a former director of research in Punjab. We are here as a part of one Word No Tobacco Day campaign with an episode on tobacco and oral cancers. And we welcome you all for the presentation by Dr. Pawan Gupta. He's M.Ch, he's director of surgical oncology in Max Institute of Cancer Care, Delhi NCR, and is a founder director of I Can Care Academy. So Dr. Pawan Gupta, he has got a special mention as master trainer and convener, certified tobacco cessation courses, which are accredited by the Gujarat University, and he's convener of Oral Oncology Connect. He's a great leader in tobacco control, and he's a leader of tobacco marshals. He's the national president and senior vice chairman, I Can Win Foundation, and he's author of many books, Tobacco Cessation, a comprehensive guidelines, Win Over Tobacco Made Easy, Be Smart, Do Not Stop, Making an Institute Tobacco-Free Guidelines. He is an innovator. He has innovated a mouth-opening device, which is called as Triscare device. So he'll be telling you about that. And he's running a campaign, Save the Youth, Chota Dana, No Tobacco, Advice, Quit Tobacco, Sync Energy. And he is member of the core committee for the C20 Integrated Health and is member advisory committee for promoting tobacco cessation under Ministry of Health and Family Welfare. So you're welcome, Dr. Pawan, to this presentation. And we know that you are a great leader and you are very passionately pursuing the tobacco cessation courses. And you are a very famous oncosurgeon. And I'm thankful to you for joining us. I know you are a very busy oncosurgeon, so thanks a lot. So you can just start with your presentation, and please share your screen.
Yeah, sure, sir. Thank you so much for giving me this opportunity. And this World No Tobacco Day, as we know, it's celebrated across the world. And there is a close relationship between tobacco and oral cancer. And where in India, if we are talking about tobacco and if we do not talk about the oral cancer, it is like we are doing an incomplete justice to tobacco or tobacco cessation program. So this is where I started this Oral Oncology Connect program, the education series where we connect with a lot of people across India, with the doctors, the dental surgeons, the general physicians and general practitioners with the purpose of educating them about oral cancers, about tobacco, the tobacco cessation. So this is what we keep on doing. So having said that, I always ask to all my patients, to all the people or the practitioners, how important is tobacco cessation in your practice? That is, when you are, as a doctor, if someone is practicing whatever field they are practicing, is tobacco cessation an important aspect for them? So this is sometime if you or anyone of you who are listening, you can just download this QR code and you can just give a single question survey, how important it is and does it make sense that we talk about tobacco cessation in the present era. Coming to the oral cancer, I call it as the king of all cancers in India, right? It is the highest, we have got the highest in the world. It is almost, the incidence is 20 per lakh of population. And almost every 6 to 7 minutes, one person is dying because of oral cancers. 30% of all types of cancer, that is almost 1/3 of the cancers in India is oral cancers. Over 5 people die every hour, right? And the age is another very important thing. Earlier when I used to practice, the age of oral cancer, the general, we used to see around 40s and 50s years of age or maybe more than that. But now in the present era, we are getting patients but just in their 20s or 30s also. So this is a very huge change that is happening. And these are the various registry, but the commonest thing is that there's an increase in the incidence by 3.3% per every year. This is another very alarming thing. And if you look at this, lip and oral cavity cancer, it forms the major chunk of all the cancers in India. And another very important is that most of the time when we see these patients, they're already in the advanced stage. That is a very pathetic thing that is happening in India. And as the stage increase, so does the survival decrease. And if you see the world over, and you can see that how important is India and Indian subcontinent, both in the male and the female, and both in the terms of incidence as well as the mortality. Why do we call it? What is so important? Why are we talking about oral cancers? As I've said, king of all cancers, highest in India. Age of incidence is decreasing. The pain is a pathetic, painful death. That is very important. Presentation in advanced stages. The survival is still pathetic. A dismal 5-year survival is only 20%. Kills the patients and ruins the family. The scenario can be changed if we join hands to work together for the society. That is what I am here for. When we all work together, we can definitely make a difference. Oral cancer is a public health problem in India. And why do we say so? Because it is a widespread disease. It is increasing over a period of time. The individuals or group who are susceptible, they are known that those who take tobacco, we know the cause, and the most importantly, it is a preventable disease. And the impact of disease on individual and society is so huge that we can definitely look for. And we know that with these oral cancers, the cause is known. Tobacco, sharp teeth, ill-fitting dentures, nutrition, and HPV. The cause is preventable. Diagnosis is easy. Treatment is curable. Rehabilitation is possible. Most of the patients can do well. But in India, 26.7 crore people are taking tobacco. And of this, almost 13 crores, that is half of them, are having some form of oral lesions that includes mixed fibrosis. So this is where what we are talking about when we join hands together with the technology, with various people, where we are able to get a good early detection, the quality and the quantity of life can be improved for these patients. And there is a huge change in the way we treat these patients. I am an oncosurgeon. So earlier, it used to be just the quantity of life which we are measuring or which were important for us. Now it is the quality of life. So we have added oncoplasty to our patients, and we are giving good quality of life for these patients who get oral cancers. And it is oral cancer management is a teamwork where we have got everyone involved. And the more importantly, the oral and the dental care and the tobacco cessation specialists, these two form the most important link for a good outcome for these patients. As I said, oral cancers has got three important features. That is, it is easily detectable, easily curable, and easily preventable. Early diagnosis is possible for these patients. The tissue change in the mouth that may signal cancer can often be seen and felt easily. That means you can see and feel the changes. If you just have to do what I call it as what we have started is a Save the Youth campaign in the society, where we are the two important aspects of this Save the Youth campaign is Chota Dana and no tobacco. That means if you know tobacco, absolutely you will be able to help yourself, or you will be able to, or you will not take tobacco. So Chota Dana is a campaign where we are looking at asking every person who is at risk. That means any person who is taking tobacco should at least examine their own oral cavity at least once a month. And that is what we see. If you see a Chota Dana, that is any lesions in the oral cavity, uski जांच जरूर करवाना. Definitely that is diagnosed, but any small lesions can be deleterious, it can be cancer. So I will quickly go through, I'll show you some of the lesions and how we are coming upwards and what are the things that we look forward for. So an oral cancer or any lesion, an oral lesion is anything which occurs on the mucous membrane. That is the layer of the buccal mucosa, the cheek, the entire oral cavity. That can, any ulcers or any lesions that is there, that is from the oral lesions, and it has the chances that it can be cancerous, it can be non-cancerous, but there can be a lot of other things that can happen to this. So how does this oral cancer develop from a normal to a cancer? It is a stage of change. It doesn't happen just in one time or one go. It is a stage of change. There will be a lot of this chromosomal changes. Like the first stage, when the patient, the novel epithelium, when it is affected by tobacco, it will go into hyperplasia. Then will be further changes. Then it will go to dysplasia. Then there will be neoangiogenesis, and then this can be cancerous. Then there could be almost like 7 steps of changes that is taking place before the patient turns cancer. What does it indicate? It indicates that early cancers or the early lesions, if treated properly, can be regressed, right? That is what I want to show in a very simple diagram. In normal, when it has got some causative factor, that can be abnormal 1, then abnormal 2, it can turn into cancer. But once it turns into cancer, there is no stoppage. It will keep on growing. But before that, if you stop, then the person may become normal, right? That is what I say. And that is where the importance of tobacco cessation comes in picture when we are talking about oral cancers in India. The 5-year survival is pathetic, and the metastatic disease is quite common in some of the patients. And what we specifically stress on is self-oral examination. That is what we call it as a chota dana examination of the oral cavity. And the other very important is that the clinical oral examination. Whenever there is a doubt, or at least once a year, every person who is at a risk should get themselves examined by a doctor, maybe a dentist, or maybe a physician, or maybe an oncosurgeon. But yes, they need to get examined, and that will change the overall survival for this patient. So quickly, what are the examinations that we do? We do the examination of the neck, anteriorly, laterally, the examination of the lips, the gums, the cheeks, the palates, the tongue, both the sides of the tongue, the floor of mouth of the tongue, and so the risk factors, as I have said, in India, the smokeless tobacco is the most important for oral cancers. Yes, when we're talking about smoking also can cause oral cancers, like the common thing that we are using, PDs and other things, that can also be harmful. Alcohol is also very important. If it is, you can see in this diagram, tobacco and alcohol, both when taken, there is an increase up to 56% chances of having cancer of the oral cavity. If it is tobacco alone, it is 14%. When it is alcohol alone, it is 5%. When there is neither, that means still there is a chance of having cancers. And these are some of the other risk factors: the sunlight, chronic irritation, lack of good nutrition, human papillomavirus, and then as a male, they have got a higher chance. So looking at the various lesions, I have divided into various lesions in the oral cavity, and the one that is definitely malignant, they are leukoplakia, erythroplakia, and chronic hyperplastic candidiasis. Those who can be associated with higher incidence of oral cancer, that is submucous fibrosis and syphilitic glossitis, serophonic dysphagia, and then lesions with no relation to cancer, that is stomatitis nicotina, habitual cheek biting, white sponge nevus, and the doubtful association is the oral lichen planus, discoid lupus erythematosus, and dyskeratosis congenita. Right. So I'll just, how do we examine that? What we do, we are thorough examination is required. I'll just quickly go through various lesions. That is, here we can see what is a leukoplakia. Leukoplakia is a white patch or a plaque-like lesions in the oral cavity. Now it can be divided into various groups. The Pindborg group, they have divided into 2 groups. One is the homogeneous and the patchy leukoplakia. The Panoxy and Sugar group, they have divided into 3 types. That is leukoplakia simplex, leukoplakia varicosa, and leukoplakia erosiva. So this is an example of a leukoplakia simplex, but you can see that it is a very smooth, and that it is there present in the oral cavity, and generally it is seen in the buccogingival sulcus. This is the leukoplakia varicosa, where you can see that it is irregular, nodular, and slightly patchy, and maybe it can be sometimes reddish or greenish. And this is another form of a leukoplakia varicosa. Then these are some of the other lesions: irregular surface, very patchy with erosions. You can see this. This is basically that is a leukoplakia erosiva, when these lesions become both there might be superficial ulceration that is taking place in these lesions, right? So this is another lesion. You can see this is erythroleukoplakia. You can see it in the oral cavity, where there is a reddish area and there is a whitish area all around, and it cannot be rubbed away. And this is the speckled leukoplakia. These are dot. You can see that is a speckled sort of a form, and this generally occurs in the bilateral angle of the mouth. And this is again chronic hyperplastic candidiasis. This patients generally would be treated with antifungal. So if we are looking at all this leukoplakia, what is the chance? The important for us is, what do we do with it? What decisions do we take? So is there a chance that this leukoplakia will turn into malignancy? yes, most of this leukoplakia will turn into malignancy, but the more the age, higher the chance of turning into malignancy. If the leukoplakia is present in the non-smoker, then there is a higher chance of turning into malignancy. And the site, when it is floor of mouth or in the ventral tongue, again, it has got a chance of turning into malignancy. So tongue and the floor of mouth, they show dysplasia. And any lesion in the floor of mouth have higher chances of leukoplakia turning into malignancy. However, the leukoplakia most commonly is present on the mandibular mucosa and the sulcus. And if you look at the chance of turning into carcinoma, the leukoplakia erosiva has almost 1/4, rather half of them will turn into malignancy at a very early stage. The others, like leukoplakia simplex and leukoplakia verrucosa, they can also turn into malignancy. But leukoplakia simplex, if the causative factor is taken care, 70% of the chance that they will regress back to normal. So what do we do when there is a leukoplakia, whenever we see some lesions in the oral cavity? First and foremost is to search for the irritant and stop that irritant. If it is leukoplakia simplex, that most of the time it will turn, when the irritant is stopped, it regresses back, and we can keep that patient under observation. All leukoplakia verrucosa and erosiva, and especially if a leukoplakia is present on the floor of mouth, they have to be surgically removed. And the surgically after removal, we have to put it in them. We have to check for the histopathology, whether there is a dysplasia or there is no dysplasia. So this is just a diagram which is showing a normal hyperplasia, mild dysplasia, carcinoma in situ, and cancer, how it looks in. So these are some of the patients I just want to showcase that how important is tobacco, quitting tobacco for such patients. Let's just look at this picture. This is in the July, this is August, this is September, this is October and November. These patients continue to take tobacco, and these lesions kept on increasing. However, these patients started tobacco quit program with our eye care center, and within 2 months, just look at the lesions. It is all gone, right? The lesion is all gone. So tobacco is important and an integral part that we have to take care of these patients, and the causative factors have to be really alluded to. So this is another patient. Just look at this, February 2021. You can see the lesions. April 21, the patient continues to take tobacco, and then it is in the March 22. You can see September 21 and March 22. You can see such extensive lesion that is present in the oral cavity. This is also what we call it as a field cancerization. And now this extensive, both the sides of the oral cavity, the buccal mucosa, you can see just extension on the palate, everywhere, and the mouth opening was also almost decreased to 2.5 centimeter. Right. So these patients were again put on tobacco cessation program, and we gave him some mouth opening exercises, and just you can look at this patient within 2 months, the entire thing had disappeared. Right. And this patient is on continuous on follow-up. So these are some of the areas, some of the lesions that we need to examine. The oral cavity has to be examined, the mouth opening. These are some of the things that we do. And most of the patients who are taking some pan masalas and supari and others, they have a decrease in the mouth opening. This is another problem that we Indians are facing, which we call it a submucosal fibrosis. And for that purpose, we have created oral cavity that is care, which is helping them to open up the mouth. So one thing that I want to stress here, there is a medical treatment available to quit tobacco. There are specialists available. There is a standard protocol available. And now we have got multiple centers where people can go and visit for a tobacco cessation program. And there is a successful tobacco program that is running. So most of the patients who will have these oral lesions, or they would be having a history of tobacco chewing or tobacco use, and they need to be sent to these such centers where they can be treated for tobacco cessation. So this is, I just want to emphasize, tobacco cessation or tobacco quit program is available, it is feasible, and it is effective. So this is just a study that I had done where a person who visits a tobacco cessation center, the quit rate is almost in the first 3 months, it was almost to the tune of 92%, which of course decreased to 39% over 2 years. But yes, still a person who has been properly treated in a tobacco cessation center, they have got a higher chance of of quitting tobacco. So this is what would be the treatment part of a oral lesions. And excision can be done. And on after excision, we do the histopathological study. What is the level of dysplasia? If it is low, nothing much to be done. If it is medium or high, we do a total excision and we put this patient on follow-up. So these are some of the other lesions. I will quickly go through that. You can see this nicotina stomatitis, or what we call it as leukokeratosis nicotina. And these are present like dotted areas in the oral cavity, parched out lesions. And this is another, what we call it as, this is the cheek bite. You know, a lot of patients come that, sir, ye hamara kya ho gaya, sir, hamare ko dekhiye. But this is a common thing, and it is a habitual cheek biting, what we call it as mercicosia quirum, right? This is in the area of the occlusion of the teeth. And this is a geographic tongue, quite common. This just antibiotics, and this is non-malignant. And if we give some antioxidants and multivitamins, this thing will disappear. So this is again what we call it as keratosis. And you can see this is very common with the patient. This is the anterior lip or the lateral sulcus. So what I want to say is another very important thing that is the submucosal fibrosis, which is a commonest disease in India. It is a progressive disease. The fibrous bands are formed. There is a trismus. There is hypersensitivity to chilies, betel nuts, tobacco, and vitamin deficiencies there. The cause is the arachidonic acid, and the tannin stabilizes collagen fibers. And the management is, of course, there can be steroids, excisions, grafting. But the most important management is basically oral cavity, opening of the mechanical oral cavity opening. And here I specifically put this because these things are very commonly available, and these are the cause. And we can see a lot of such advertisements coming on even in TV. But the most important is that such advertisements, such masalas should not be taken at all. And this is management of the trismus. And these are some of the other lesions. Just I want to stress here some of the lesions of the carcinoma. These are something what we call it as incidentally found lesions, that you can see that there is a very small lesion that just an excision will be of help. And these are some hidden lesions in the oral cavity, which is upper. If it is not examined properly, you are likely to miss it. And then you can see some small lesions, which are malignant lesions, but can be taken care with simple excision. This is melanoplakia, smoker's patches in the oral cavity. And then you can see with the small patch, there is a very small lesion, maybe of 0.5 into 0.5 centimeter, that is present, and if it is likely to be missed. So these are some of the lesions. And here, what I call it as a coffins area, which is the lateral floor of mouth. Generally these lesions are hidden, and until you move the tongue to the opposite side, you are likely to miss these lesions. So this is a general examination of the oral cavity, where we examine the oral cavity entirely from external oral cavity, the internal, the neck, everything is examined, so that we don't just a small video showcase how to examine the oral cavity. First and foremost, you can see that the two fingers, if we just measure with this, so we can measure it with the TriScale instrument. It is approximately, so it is a 2.5 centimeter mouth opening, and we have to examine in clockwise or anti-clockwise direction from one buccal mucosa to the under buccal mucosa entirely. Upper palate, upper lip, the hard palate shows some nicotinic stomatitis, small lesions, submucosal fibrosis, and there is a submucosal fibrosis, entire lesion, the lower lip, the upper lip, the gingiva, the tongue, that has to be examined. And more importantly, we have to examine the deviation lateral floor of mouth and anterior floor of left side, right? And if you will see, there is nothing else that is noticed when we examine this way. But if you examining by pushing the tongue away is very important, because that is the area. And this is the coffee area. Here you can see it is normal. When we remove this side, there is an ulcer that can see that there is an ulcer. So these are some of the other lesions that can be seen. And the mouth opening is a very important. And these are the types of centers that we are looking forward to set up at all the places in all the hospitals. And that is my recommendation, that any hospital which is more than 100 needs to be examined, needs to have such centers. So just 6 messages, very important. Be smart, do not start. We know what tobacco is easy. Be careful and fearful. Chota dana, that is a self-examination. No pan masala and some mucosal fibrosis is a very common thing. And be a tobacco marshal. So these are the 6 messages that I want to give. And being a tobacco marshals, we have to control this demon, that the tobacco asur. And that is why we have started this I Can Care Academy, where we are giving the training program, that like the marshal training program, the ambassador training program, the cessation specialist training program, and it is at the various levels. So certified tobacco cessation specialist, orientation courses in tobacco cessation and tobacco marshals. And right now we have got a special program where we are giving the scholarship for those who want to be trained, especially for the doctors and professionals, about a special scholarship. So we are by now we have trained more than 1,000 across 25 states, and we are looking for, and what we are trying to make it is a very simplified methodologies of oral care, tobacco cessation, and oral screening. That is through this app. That is what we call it as an I Can Care app, which is a really available and present everywhere. So this program or this app and the program that we are running, it was presented in one of the Global Digital Health Summit, where more than 35 countries have participated. It was well appreciated. So what we look forward is that we need to have the institutions, hospitals, and the manpower and technology that is there with the I Can Care, that we can join together to give a good solution. And of course, we have to get more and more tobacco marshals. So I think I will stop here, and I look forward for all of you to join my community page and be part of this campaign, the Save the Youth campaign. Thank you so much.
Thanks a lot, Dr. Pawan. It was an absolute pleasure listening to you, and it was definitely a very well presented session. Lot of pictures, and I think all healthcare professionals will benefit if they watch this video. This brings us to the end of the session, and thank you so much, Dr. Pawan, for your time and efforts in putting together this interesting session. To our dear viewers, thank you so much for attending this session. And do share any more questions if you have. So Dr. Pawan will like to answer them if you have any queries. So until then, we see you again. Take care. Thank you.